We'll just give it a minute for people to join in, and then we'll start. Another 15 seconds. Right, a very good evening, ladies and gents, and welcome to the penultimate episode of the British Hip Society Midweek Special. I'm Vikas, Khanduja, consultant orthopedic surgeon in Cambridge and president of the society, and it's a pleasure to welcome all of you to this webinar. Now, our aim with this series has been to bring to you clinical cases and discuss intricacies of decision-making and management from key opinion leaders in the UK, so that we can continue to fulfill the society's aim of sharing knowledge and improving patient care. We've already had 2 excellent webinars in the Revision Hip series, and today's session is focused on dislocations, every hip surgeon's nightmare. Moderating the session today will be our past president, Mr. Stephen Jones, who's kindly joining in from Germany. And along with him, we have also got stellar faculty who joined us and given up their time for this. And I'll let Steve introduce them to you in a minute. We're also delighted to be partnering with OrthoTV Global for this series and welcome all the viewers from the Asia Pacific region who are able to watch this event streaming live at no cost via OrthoTV. Thanks, Ashok. We strive to make every session as interactive as possible, and therefore please do post in your comments and questions in the Q&A box. Our panelists will address these questions as we go along and choose some of them to discuss live at the end of the webinar. For those of you who can't join us live today, we've got the option of on-demand viewing as well via our educational platform, Pinocto. So without much further ado, once again, a very warm welcome and hope you enjoy this series and this evening as well. I'll hand over to Steve. Steve, over to you. Thanks.
Thanks very much, Vikas. It's great to be here this evening. Quick word of congratulations to yourself and good luck for the year ahead as president of our society. And I'm going to start by just saying thanks in advance to the faculty who've kindly joined us this evening, not just busy orthopaedic surgeons, but very big contributors to our society. Samantha Hook from Portsmouth now, an important member of our diversity panel and committee. Henry Wynn Jones from Wrightington, who's our member at large, and of course, Andrew Manktelow, past president of the society. So a stellar lineup, looking forward to the case discussion that we've got ahead. So sticking in with the remit of the series that Vikas shared with you, very much going to have a case-based discussion this evening. We've got 6 cases for you, and really, they've been chosen to be, of course, real-life problems. These aren't manufactured. These are real patients with challenges that we face. And we're going to look at the spectrum of problems that the dislocating hip can present to us, from straightforward primaries to multiple revision cases. So the batting order is going to be Sam, then Henry, and then Andrew. I'm in charge of slide advancement, so there's going to be no more sharing of the screen. So without any further ado, I'm going to hand over to Sam, who's going to take us through our first case. Thanks, Sam.
Perfect. Thank you, Steve, and good evening, everybody. So I'm going to start off with some sort of relatively straightforward, simple dislocation cases. Again, as Steve says, real-life dislocations all happened to me relatively early in my consultant career. I think things I could have done better, things I could have done differently, but actually stuff that's taught me a lot and I've learned from. So these are my disclosures. Next, please. So my first case is one that I did in 2015, 62-year-old gentleman, fit and healthy, enjoyed windsurfing. I think you'll agree from that x-ray, nothing particularly complicated about his hip. And I went on to do a straightforward hybrid total hip replacement on him. I was pretty happy. I think I've got my leg length pretty good, not far off, perhaps very, very slightly short, but not excessively so. And I think my offset is pretty well reproduced from his normal anatomy. He was pleased. He got up, he got going, he got out of hospital pretty quickly. But then next, sadly, at 2 weeks, he dislocated post-operatively, dislocated anteriorly. I can't quite recall the exact details of what he was doing, but it was something pretty innocuous. It was nothing crazy. He was a sensible chap. Again, I can't quite recall whether I braced him at that point, and I don't have access to his notes anymore because I'm now in a different trust. But we obviously relocated him, and then unfortunately he dislocated a few days later. He was a very sensible gentleman, but he was also a little bit anxious, and he lost all confidence in his hip replacement. And to be honest, I lost confidence in his hip replacement, and I felt really guilty because I'd given this gentleman a hip that had taken away his arthritis pain. He was looking forward to getting back to all his activities, and now he was in that anxious state of a hip that, yes, wasn't painful when it was in joint, but wasn't staying in joint. So reluctantly, but and I think probably slightly too rapidly, I felt a bit pressurised by him and by my own sort of lack of confidence, I suppose, and I revised him at 2 weeks. And I thought, well, I haven't quite got the uncemented socket right. I think my problem was I had too much combined anteversion. I think the socket was too anteverted. And even though I'd given him a 36 head, which I think I'd done because I knew he was active and wanted to get back to windsurfing, it just didn't have the right stability. So I thought, well, I know I can put a cemented socket in a good position. I'm good at cemented sockets. I know I can take that anteversion off. So I went in and I gave him a cemented socket, kept the 36 head, kept the original stem actually. And he was fine. He got up and he got going and he was much happier. I kept him under follow-up. So next slide. But he just, although he was happy because the hip was in joint and it was stable, he just was slightly persistently discomfort. Despite engaging in physiotherapy, he was getting increasing stiffness. And he was really engaged in his physio. He would regularly go. He worked really hard with them, but he just was struggling to regain his range of movement. And actually, serial x-rays showed that he was starting to develop some heterotopic ossification. And he just wasn't quite right. So we did a bit of investigating and his CRP just grumbled on occasions. And so I investigated him for infection. And he did have a sure that the proximal cement bone interface was intact, and then treated the cement bone interface as one construct. Birded up, used Palakos cement. And obviously this all went through an MDT discussion within microbiologists beforehand, and it was a favourable organism to do a one stage and treat him appropriately. And he did fine and actually did well and was happy. So things I learned from this case were I had too much combined version on it. I think my socket was a little bit too anteverted, and I'm sure other people find this, but maybe I'm just not as good at uncemented sockets. But I find when you have that sort of final impaction, they often tip a little bit more into anteversion and a little bit more into a closed position. And you're then in that position of, do you take out what is now a really nice, stable, primary fit cup and just try and take that little bit of version off, or do you accept it and hope it's going to be all right? I didn't take the cup out and reposition it. I left it where it was. I don't honestly recall it being overly anteverted when I looked at it. I tested the stability on the table. I was happy, but in hindsight, it was probably too much version. So I think that's that to consider. I think with him, I should have held my nerve. I should have braced him. I should have persuaded him that we could probably stabilize him with bracing. These early anterior dislocators, I think if you brace them and stop them from extending and externally rotating, you can often get the anterior tissues to stiffen up and scar up a little bit and prevent them from dislocating anteriorly and get a good result. And I think, revising something at 2 weeks post-op is fraught with problems. There's a high risk of infection, and I came a cropper for that. So it probably wasn't my wisest move going back in at 2 weeks. But what I also learned was communication. And even though this gentleman's hip didn't go brilliantly, I kept seeing him. I kept looking after him. He could come back to clinic whenever he wanted. We talked a lot. I explained what I thought was going on. I explained that I didn't think I got it right the first time. And then we just kept doing, I hope, all the right things. And despite the fact that it was a bit of a rocky road, he got there in the end. And actually, he stayed on side with me. He seemed to still respect me and like me as a surgeon. And actually, I think we had a satisfactory outcome. And I think it's really important to involve the patient in the communication all the way along, particularly when things haven't gone well.
So great case to get us going, Sam. Excellent. So just to confirm, when the other guys are dialing back, turning their videos back on, you're a posterior approach surgeon?
Yeah, posterior approach surgeon.
So there's a question come in on the chat. Do you routinely do an anterior release in your primary total hips?
Not routinely, but in those muscular, stiff 50, 60 something year old gentlemen, then actually I find they often do need a bit of a release of the reflected head of rectus just to get the to be able to expose everything and see adequately. So I may well have done in him, and I take a little bit of thickened anterior capsule out, but only if it's thickened and I think it's going to get in the way and cause potential problems with impingement. But I try not to release too much.
So, Henry, great case to illustrate that really when you have an early revision, the risk of subsequent re-revision is just so much higher. Up in Wrightington, what's your workflow algorithm, if you have one, for dealing with the first-time dislocator?
So I think it depends on whether it's anterior dislocation or posterior dislocation slightly. And I think also it depends on the radiograph. So if there's sometimes there's something banned or obviously gone awry with the operation, so extremely antiverted socket or something. Whereas in Sam's case, there was nothing grossly amiss with the X-ray. So I think that helps you to decide whether you can get away with bracing it, let the soft tissue stabilise and heal up, or whether it's highly likely to just keep happening because there's something grossly amiss with the combined version. So I think that would be the thing. And I think Sam eloquently put in the part about communication. I think the very helpful thing in these early complications as the surgeon is to ask another surgeon who's not directly involved in the patient care to discuss and maybe review the case with you, because sometimes that's very helpful for clarity of thought for someone who's not directly responsible for that patient, to help you with your decision-making process as well. But other than that, I think I completely agree with Sam's comments.
So, and Andrew, and a comment from you, we know that 80% of dislocations happen in the direction of the surgical approach. You're a posterior approach surgeon as well. An anterior dislocation after a posterior approach, red flag for you? What are your concerns with that?
Yeah, so I think it's unusual. I don't do much of an anterior release unless there's a specific reason. Sometimes you can do a little sneaky anterior release off the very anterior aspect of the neck so that you can allow yourself a little bit more mobilization, but at the same time don't damage the anterior structures. I think if you do get an acute anterior dislocation for a posterior approach, there's often something going on, maybe a bit of posterior impingement with a liner, something else that's just slightly difficult to see. So it is a red flag. But again, we've just seen there was nothing obviously overtly wrong with that surgery.
Great. So we'll keep going at pace. We've got a lot to get through. So we'll go back to you for case number 2 then. Thanks, Sam.
Okay, thank you. So this, as you can see from the X-rays, is a fractured neck of femur case. So this was a 67-year-old female, fit and well, tall, a bit overweight. What I'd sort of describe as and this is going to be a bit controversial, a saggy, muscled female. So you didn't get the impression she did a great deal of exercise to keep her muscles strong. Didn't get the impression she had a great deal of sort of core stability. But she was pretty fit and healthy. She enjoyed caravanning. They had a caravan in a local holiday park, and they enjoyed going there. Next slide. Well, you've given the game away, Steve. Can you go back a slide? So I gave her a standard cemented total hip replacement, and I was pretty pleased with how her x-rays looked. Again, I think I've got her offset okay. I think I've got her leg length okay. And I think the components look nicely aligned and nothing particularly crazy. Next slide, please. So she did really well, actually. But at 6 months, she dislocated. Now, she had gone to her caravan at Hayling Island and was doing a bit of dancing at the holiday club. And I think perhaps slipped slightly awkwardly and dislocated. She was reduced to the local hospital, which is now my hospital, Portsmouth. My colleagues very kindly told me about her, and then she came back to see me. She wasn't braced or anything like that, and she unfortunately dislocated again a month later. I sent her off for some physio because as I said, I didn't feel that her muscle control and muscle tone was great. And I thought, actually, if we could strengthen everything up a little bit, we could hopefully stabilize this hip and not need to do anything else. And actually, she was really sensible, really engaged. And we managed to get her to settle, and the hip stayed in joint. So good. Thought I was onto a winner. Next slide. So she came back to see me 6 months later and she said, oh, my knee's a bit painful now on the same side. It just feels like it's collapsing. I feel like I'm getting more knock-kneed, and it's painful. So we did some x-rays and she had obviously a valgus pattern of arthritis and she was quite symptomatic from it. And what she said to me was, do you think the fact that my knee's getting a bit wonky could have been affecting my hip stability? And I said, well, do you know what? It's a good thought. And actually, if it's in starting to collapse and let you down, then let's do something about it. So we went on and did a knee replacement and that was very successful and she was happy with that. And she did really well. But then 4 years later, so actually we had a good few years, she then got a few more dislocations and she had several in quick succession. And despite it continuing with her physio exercises, it was just impacting on her lifestyle and it was frustrating her. So I revised her to a dual mobility socket. So I think I did an in-cement revision of the stem and then just as a cemented dual mobility socket. And she did really well. So lessons I learned from this was that neck of femur fracture, although she was fit and healthy, actually her muscle strength, her muscle control wasn't great. Should I have done a dual mobility initially? It isn't my routine. My feeling is that if they are good enough for a total hip replacement with a hip fracture, that they're good enough to have a standard total hip replacement that I would give to somebody coming in with primary arthritis. So I don't routinely use dual mobility for neck of femurs. Should I have done a hemiarthroplasty? Does the health trial that's been recently published tell us that actually we're doing too many hip replacements for these patients? Should I not even have done a hip replacement? That said, she then went on to have another arthroplasty surgery. So I think, I think she was fit and well enough to have a total. Early in my consultant career, I was routinely using 28 heads, and I think I probably also wasn't routinely sparing piriformis at that stage. So I now absolutely would use a 32 size head on her, and I would definitely leave piriformis intact. So I think, I've learned a lot about sort of just my surgical technique and lots of different aspects of that. And I think look at the whole patient really carefully. I probably didn't look at her knee properly when she came in for a hip fracture. It was probably, she's got a hip fracture, she's fit and healthy, she meets the criteria, let's give her a hip replacement. And I think you've got to be really aware of what's going on above and below the hip. So I think it's, don't just look at the joint you're operating, look at the whole patient.
So Andrew, I'll bring you in first for a question on this case. Patient risk factors for instability. This lady had a significant one, neck of femur fracture, so total hip replacement for fracture. What's your approach to that scenario? Use your standard implants? It's the same type of hip replacement you do as normal, or do you do anything different?
So, I now use the posterior approach. When I was doing more trauma, I think I actually used the anterolateral approach if I was doing a total hip replacement sometimes to try and improve my stability. I use my routine approach now because I think that's the right thing to do. I have to say that I tend to do more hybrid hip replacements, which I think can give me options from the point of view of increasing the head size. And I would routinely try and get out to a 32 or even a 36 millimeter head size at the time of a hip replacement for fracture. I think dual mobility does have a role, but I think for me, that would come in if I had another factor that meant that dual mobility was sensible. Sometimes you get into these patients and the abductors are poor, or there's an abductor defect, something else going on that might increase or take them further up that risk. So I think they're difficult operations to do because they're difficult operations to tension correctly. So there are lots of things that are different about doing a hip replacement for fracture. I think Sam's made all the important points in terms of considering other options and enlarging the heads, caring for the soft tissues, and really counselling the patients very well before you do the operation.
And I'll come to you, Henry, with the last question on this case, and one that's come in via the chat. Lipped liners. Do you use lipped liners routinely in your practice? Is this the sort of scenario where you would use an elevated rim liner?
Well, my disclosure, I suppose, virtue of cemental hip replacement, especially for neck femur fractures. So the cup, I use the Marathon cup, has a slightly raised posterior wall anyway, much like a Charnley cup. But that's my routine cup that I use for almost all arthroplasty, but especially for osteoporotic neck femur fractures. So lip liners, that I don't have any experience of using uncemented cups for neck femur, so difficult for me to answer that, honestly.
Okay, we'll keep moving on. Thank you to those people out there submitting the questions, and Sam's going to take us through her last case. Thanks, Sam.
Thanks. So my last one is another lady, a 70-year-old lady who'd had a previous right total hip replacement done through an anterolateral approach, with which she was very pleased. She was known to have chronic back pain and spinal stenosis, and she was short and overweight. And again, as I described earlier, a slightly saggy muscled female, but she was pretty fit and healthy. And she has clearly got arthritis. So we went on to give her a standard cemented total hip replacement. And again, I think I've reproduced her anatomy pretty well. I think on the other side, I think her offset had been reduced, and I think I've reproduced it to pretty much where it was pre-operatively on the side I've done. It's probably not my finest looking hip replacement ever, but I think it's okay. And so she sort of went on her merry way. Next slide. But sadly, she dislocated 3 times in pretty quick succession. I did send her down the physio route, and she struggled to engage with physio. I think that was a little bit of a problem, and she just kept dislocating and was very unhappy. So I decided to revise her to a dual mobility, and I did that at about 6-month mark. And following that, she was fine. She still continued to have lots of back pain, and actually back pain was always an issue for her. Once her hip pain had gone, and even post now stable hip, she struggled to engage with physiotherapy. So next slide. So I think lessons learned. We've talked a lot about spinopelvic mobility in the last few years. But if I'm being honest, when I did this over 10 years ago, and I know it was over 10 years because that's a CPT stem, and I only used that for the first 6 months of my consultant life. And if I'm honest, I didn't think about her spine. I knew she had chronic back pain. I knew she had spinal stenosis, but it didn't cross my radar to do anything different other than a standard cemented hip for her. I didn't think about it. Again, she's got a 28 head. I'd give her a 32 head now. And the physio, I recall with this lady, I sent her off to have some physio, and she did go to the physio, and then she came back to see me several months later, and she said, well, I did the physio, and I think they were obviously working on her gluteal muscle, and she said, and the next day I was in so much pain, I had to phone the GP, and the GP told me to stop doing the physio immediately. And I just thought, oh my goodness me, we're up against it, because actually that pain she's experiencing is just delayed onset muscle soreness from making a muscle work that she hasn't used for a while. And actually all the GP's done is to totally scupper any ability to try and rehabilitate this woman. So physio only helps if you can actually engage in it and get through the hard work of physio. And I've also learned that it doesn't matter how much you communicate with some patients and how much you try and do the right things, they'll never be happy.
Thanks, Sam. So what that brings up for me, that case, Henry, if I come to you first, is the investigation of the dislocating hip. And Sam mentioned spinopelvic issues. What would have been, before Sam went down the route of the dual mobility, which I think has clearly been a good option for this patient, how would you work up and investigate this patient?
So I think it's helpful to consider the back and to consider the hip itself, isn't it? So if you're not too sure why it's dislocating, I think it's helpful to get an idea of the combined version in 3D with a CT scan. And then if the patient's able to get sitting and standing, and you're able to in your department get sitting and standing spine x-rays, that can be very helpful. I have to say it is a bit of a mental minefield trying to think through what the sitting and standing x-rays mean. It all makes sense when you read it and you've got it there in front of you. So you really do have to sit down and think about it. My personal feeling is that I don't know what the other panelists think. I'm not really clever enough to think how I would dial in the version differently based on those x-rays. But what I do think it does is maybe help you think that maybe a higher level of constraints, such as the dual mobility, is helpful, or a bigger head if you've got a small head. That's sort of the way I would approach it.
And Andrew, I'll come to you with a question that's come from the chat. A comment about bracing. Is that really effective? Do braces have a role in your practice, Andrew?
Yeah, I'd love to say no, but that's not true. I actually think that the braces do have a role. They're very cumbersome, and we have to understand that patients really don't like them, nor should they like them. But I do think they have a role really in the acute dislocation. So where you've got someone, perhaps like the case that we discussed first off, maybe not with an anterior dislocation, but where you've got an acute dislocation following surgery. I think the brace, if it's fitted well and you make sure that it's not going to cause any pressure areas, just reminds the patients just to protect the range of movement, particularly with rotation in the early part of their rehabilitation. And so I think I do use them in that particular instance. I think if you've decided you're going to have to revise somebody who's had multiple dislocations, putting them in the brace just to protect them for a few weeks while you get all the kit organized can be helpful. I don't think it has a great role to play in chronic instability in patients where you're going to have to get on and do something to fix it up. But yeah, I think they're useful. But make sure they fit really well. Speak kindly to your occupational therapists. Explain exactly what you want them to do, what the range of movement you want to protect. I think it's important to communicate with that too.
Yeah, I would agree with that. The brace doesn't stop hips from dislocating, but it reminds patients to avoid those positions where they're at risk. I think that's what a brace achieves. So thanks, Sam. Great cases to get us underway. Henry, over to you with Bryn.
Classic mistake. I forgot to unclick my microphone. Yes, Bryn is a gentleman who I learnt a lot from. He's a big gentleman, retired rugby league forward with a rather large high BMI. So he first had the joint replacement. Next slide, Steve. Way before I was an orthopaedic surgeon in the early 90s, had both hips done. You can see I had trochanteric osteotomy approaches, left one with a small head. I think the right one might have already had a socket revision at some point, as you can see by the slightly larger head for that time in arthroplasty. So he was doing okay at that point, I understand from the records. The interesting thing about this case is that it can be, when you're presented with a very difficult dislocation problem, very helpful to get a picture in your mind of the history of the patient's orthopaedic surgery. So this case eventually developed a socket loosening and underwent a revision on the left-hand side. And as you can see there, it's been revised to a cemented socket. Interesting, which we'll discover later, is obviously an awful lot of bone cement in that socket, and not so much bone grafts. But he actually had a really enormous acetabulum. He did quite well for a number of years. He was investigated for back pain at some point. You can see his abdomen gradually gets bigger and bigger as the slides progress. And you can see his spine lights up like illuminations. And already there, back in 2015, his back's looking in pretty bad nick. Next slide, please, Steve. So unfortunately, he then went on to start to become unstable. Having had his revision done in 2010, 8 years later, he started to develop recurrent dislocations. An interesting point here on the lateral is that on the AP, the version of the socket doesn't look too bad. But on the whole series of x-rays, on the lateral, in the lying position, his socket looks comparatively retroverted, suggesting that something's happening to his pelvis in space, a combination of his very stiff back and perhaps his enormous abdomen as a force of leverage on him. So maybe that's a contributing factor you're starting to think as you go through these x-rays. Next slide, please, Steve. And then you can see here, you can comment on the position of that cup, but to be frank, this gentleman is absolutely enormous. So I think it was a rather challenging situation. And I think when it was performed, it was felt that simply doing a cement on cement revision of the cup to minimize his surgical time was the most appropriate thing. So clearly the cup is steeper than one would hope for, but it's interesting to see how his hip is quite lateralized and his combined offset is quite high, but the offset of the femur itself is not that high. Next slide, please, Steve. And so you can see there, unfortunately, the socket has actually started to roll out of the cement. So whether that was due to some impingement, due to this pelvic stiff back, enormous belly, huge weight, or whether it's just simply levering out due to poor fixation is impossible to tell. But clearly the mechanics of this hip are not ideal. Next slide, please. And again, you can see now his back is even stiffer than it was before, multi-level stiffness all the way from his sacrum up to his thoracic spine. Next slide, please, Steve. You can almost now not see what's going on at all on the hip, but you can see from the clips it has been revised, and another dual mobility was inserted, but preserving the stem. But in what radiologically on the AP X-ray looks like a better orientation. It's a bit closed down and inverted, but unfortunately, it didn't stabilize his hip. In fact, it had the opposite effect, and he got recurrent dislocations. He had it reduced, it popped out again, it reduced and popped out again. Next slide, please, Steve. Oh, sorry, I've given the game away now. I thought there was an AP without a dislocate. But so he had 2 or 3 dislocations in very short succession at this point in time. And so I was then presented with a situation with a very large gentleman, BMI heading towards 60, who'd had a revision and 2 or 3 EUAs in very short succession with this position. So I think what was very helpful here was to go back through the x-rays. I couldn't get sitting standing x-rays because he was in a dislocated state, unfortunately. But looking back through the x-rays, we could see his spine was extremely stiff. The interesting thing on the horizontal cross-table lateral is that he looks retroverted on the cup, but on the AP film, he doesn't. So clearly his pelvis is functioning in a way that's not optimal for constraint. The offset of the femur is really not great. And even with that plus head, it doesn't look like he's got a matched offset. And the offset is achieved by lateralizing the cup as opposed to perhaps recreating the biomechanics of the hip. So the challenges here are to work out what we can do to try and stabilize this gentleman who already has a dual mobility component with a very narrow canal, abnormal spinal mechanics. So perhaps do you want to go on to the next slide, Steve, and then we can talk around the panel about what others may have done. So at this point, I elected to try and address all the issues. He had quite significant bone loss as well as a dislocating issue. So the way we chose to address this was to revise the socket, to put it perhaps in a more medial position. That was a 68 cup, which is one of the larger TM sockets with an augment. And so we brought down his center of rotation. I wanted to increase the femoral offset to maintain overall offset, but to avoid under offset femur and impingement that way. So we revised him to a 56 number 1 offset Exeter. And I did debate whether a dual mobility then would be adequate, but this guy had been through a lot, so I elected to use a constrained liner. You can see I really tried to dial in a lot of version here. I thought I'd put in a lot, but interestingly, on his lying down AP film, that looks neutral, if anything. So clearly his spine and the pelvic position can be quite confusing. But thankfully, his wound did heal. I did use antibiotic-loaded bone cement both into the T-Mars revision cup and around the femur. But there still remains the concern that he could impinge and rip out this or break the constraint mechanism on this liner. But I found this quite a challenging case, but a very interesting learning point to go back to his previous x-rays and try and pinpoint the multiple factors that led to this poor outcome. And I think what I learned from this is you need to try and address the constraint is not the answer to the problems elsewhere. The constraint for me is an adjunct to optimizing all the other factors. So I'll perhaps pause there and Steve can...
Yes, I'll bring you back in first of all, Andrew. Some nice follow-up pictures there as well, Henry. So major bone loss. This looks like a 3A defect here, Andrew, with a superior augment. Major bone loss and instability, two challenging situations. Have you got a method how you sort those out in your practice?
Yeah, no, a major problem and dealt with very nicely here with an x-ray that shows clearly things have worked very well. But Henry made all the important points, and that is the concern with using that level of constraint with that level of bone loss is that you're going to compromise your fixation before you've got a chance for that to be established. So in those circumstances, what I've done quite regularly is I've affected my reconstruction and perhaps used a slightly less of a level of constraint. Given it the benefit of the doubt, I with a 36 millimeter liner, or possibly even with a dual mobility or something else, knowing to the patient that I may well have to come back and convert that to a captive liner. So it's something I'll discuss with the patient beforehand to say that there is a risk of instability. We're in trouble here with this case. What I want to do is to try and deal with your bone loss, to give you something into the acetabulum that's rock solid that we can work with over time. There may be a problem with instability, but I've got an answer to that if there is. So I think staging that is something that can be done with those circumstances. But if you have to, and if you've got no abductors at all and you really feel you need to use that constraint, then just making sure with an uncemented device that you use plenty of screws, that you do everything you possibly can, take it carefully. You know, these devices, Steve, as you've taught us, are impingement devices. So you need to make sure that you put these liners in the right place to make sure that you don't get impingement that you're not expecting. So I hope that's an answer to your question.
Yeah, definitely. And I think I would just emphasize a comment that Henry made where he talked about optimizing the position of the implants and using a constrained liner. Constrained liners, there's no doubt about it. They are a salvage device. The systematic review that we published showed more than 10% of them fail in less than 5 years. But a great paper from the Mayo Clinic on their outcome and results with constrained liners. And a key message from that is exactly what Henry said, where you optimize the position of the implants to try and give the constrained liner the best possible position and reduce that impingement. It's so often a knee-jerk response to, particularly in a modular cementless cup, to exchange the liner without correcting the underlying problem with regards to component malposition. So I'm going to come to you then, Sam, and bounce a question from the chat and Q&A. This is around, we've seen several dislocating hips as well. That's what the theme of this evening is. But what we haven't mentioned is technology that could help us to try and prevent this. Any navigation, robotics, or other alignment jigs. Do you, in your practice or in your unit, use any of those technologies, or have you got any comments on that?
I don't currently. We do have a robot, but it's only for knees at the moment. It hasn't got the hip software on it, and none of us have been on the validation course. It arrived before I arrived, so that is my desire to go and be robot validated. The answer is I don't know how valuable it is, and I'll be honest, I don't know what the data is in terms of outcomes and for example for dislocation with robot assisted hips. But I have to say, my first case where I had too much anteversion on my cup, actually if he'd had his templating, his 3D templating with the robot, and then the robot had effectively put the cup in for me and not allowed me to antevert it a bit more and close it down a bit more, maybe the outcome would have been different. I mean, that's my understanding of how the robot is useful, that it just controls that arm for putting your cup in and stops you moving it out of the position that the templating tells you should put it in. So maybe that is useful. I'm happy to be corrected, but I suspect we haven't got quite enough outcome data yet to know whether it's going to make a difference or not. But I'm willing to give it a go.
Time will tell. Henry, I'm going to come back to you with a question from the Q&A, particularly knowing the experience that you have in Wrightington with dealing with THR following complex acetabular trauma. One of the delegates has asked, in dislocated hips previously operated for acetabular fracture fixation and subsequently needing THR, any special challenges and protocol you follow to try and prevent dislocation? So this is the post-acetabular fracture, THR and dislocation.
Right. So I think I might think the question is particularly with regards to avoiding dislocation in these patients, given the forum. So in actual fact, the biggest challenge is heterotopic ossification in these patients, unfortunately, which is the approach is a real challenge. So with regards to dislocation, obviously, the issue there is if you have a big lump of HO at the front that's going to impinge and you take it all out at the back, put your hip in, but don't address the anterior impingement HO. So I think a CT scan is pretty much essential in these cases to assess the anatomy, largely because the bone loss that can occur can be completely out of the plane with the AP radiograph, and you can have a very deficient posterior wall. But it's also extremely helpful to work out where any HO is around the hip, because that can be a big fulcrum for extra-articular impingement. So I think that would be my main advice there. And in actual fact, the main risk is they really stiffen up and get even more HO than they had to start with. But
Great. Well, thanks that, and thanks for the questions that are coming in. We've got permission to drift with our time, and we are going to hand over to Mr. Manktelow now, who's going to take us through a couple of cases. Andrew.
Yeah, thanks very much indeed, Steve. Those are my disclosures. They're not relevant to this presentation. So let's have a look at the first case. This is an interesting case. She was 35 at the time she was referred to me. She'd had previous hip surgery and indeed subsequently a hip replacement and indeed a revision. She was referred to me, as you can see here, with this cemented construct with a failed acetabular osteotomy, failed trochanteric osteotomy. Her problems, really, from her point of view, was that she had a hip that was unstable, it was dislocating. She had pain in and around the lateral aspect of the hip, and she had this instability as well as a long leg. If we look at the next slide, you can see we've got a slightly oblique X-ray, and you can see there that she is long on that side. Looking at the X-ray, my other concerns here were to do with perhaps a slight loss of offset. She's got quite a varus hip on the other side. So perhaps the surgeon involved had taken up that soft tissue tension with a little bit of length, and the offset wasn't quite right. So quite a challenge, actually, Steve, in terms of what to do. So I don't know if you want me to just go through and see what I did, or whether we
that would be a good one for this
case. Or we'll go see. So what I thought would be interesting to try and do is to try and to correct the biomechanics of the hip. One of the useful things, if we talked about access, was to use that trochanteric non-union as a way, almost like a trochanteric slide. So I could actually freshen that up, keep that out of the way to get access to it. She's a relatively young lady. And so I wanted to try and be conservative in terms of the revision. And I was able to do an in-cement revision on the acetabular side, increasing her head size and slightly improving the orientation of that component. And at the same time, to do an in-cement revision on the femur, shortening that leg up slightly, but increasing the offset, so that I'd improved the biomechanics from that point of view. I'd improved the biomechanics from the point of view of the bearing. I used a cross-link polyethylene and ceramic bearing. And then I did what I could on the trochanter, as you can see, by bringing that back down with the device that I felt was the best available at that time. So there we are in 2014, and that was my answer to her problems. She was pretty happy, Steve, for 4 years, no further instability. But unfortunately, as you can predict, to get that trochanter to unite back against a cement bed is a challenge. And that trochanteric plate failed, and that became symptomatic. So 4 years later, I'm afraid to say that I might have succeeded in one area, but I've failed in a second on that trochanter. And just for the interest of honesty, Steve, I'll ask you to move on, even though I don't want you to move on. And we'll move on again to 2021. And as you can see, Steve, I've got a problem here with my trochanteric plate that has now failed, though there's thankfully enough soft tissue around there to hold the trochanteric fragment in place. It's not migrated further, and the hip remains stable. And I'm probably still in a slightly more conservative position than I could have been if I'd done a more major reconstruction. So there we are. I've solved one problem and created, or at least haven't solved a second.
Well, I think this is a great case to demonstrate trying to optimize as many facets of the issues that have contributed to the instability as possible. You've increased the head-neck ratio, you've increased the offset, you've addressed component malposition very nicely with a very conservative in cement acetabular revision that we don't do much of. And I think, you're selling yourself short with that trochanter. You've held it in that position, so you've got some fibrous ingrowth now, or fibrous fixation. But we're fortunate. We've got Henry online, who works in Wrightington, and I'm not saying that you'll have a huge experience of this problem, but you will have an experience of putting them back. So this is a challenge for us as hip surgeons, isn't it? Managing the trochanter that's escaped. Give us some pearls of wisdom, Henry, so that we can do as good a job as Mr. Manktelow.
So obviously, over the years, thousands of trochanteric osteotomy approaches have been done in our region and in our hospital. And there's a fair few out there that haven't united. And it's always a real challenge to know what to do at revision surgery, because you really want to bring it down and make it look like a femur again and have that muscle attached. I have to say, I've only ever been talked into trying it once by a colleague, and I swore I'd never try it again, to be honest. And this patient had a much higher trochanteric non-union, and this is really rather an unusual situation. But in the end, we actually attempted to get it to the only way we could get it anywhere near the femur was to actually do a temporary pseudarthrosis, fix it back, and then come back in as a second stage later on. I have to be honest, it virtually involved excising the trochanter from the muscle to get it anywhere near the femur. So I think what really happens is that the muscle really shortens up. What is interesting is very frequently there is a really thick fibrous band joining the trochanter to the femur. So although it's high, there quite often is a thick fibrous band down to the vastus lateralis, which I think is somewhat different from this completely naked gap between the two. So it's a challenge, and I think when you're doing the revision, you do have to think about optimizing everything else to compensate for the fact that that tether is deficient. That's how I think.
Sam, you got any top tips for dealing with trochanteric failure? The multi-fragmented DHS that you convert to a total hips, that sort of thing.
I don't know that I've got any top tips, and I was going to quote the words of a wise man, but David McKenna, I can see, has put on the chat the words of a wise man. Once a trochanter has tasted freedom, ... I think thinking about that multi-fragmented DHS that needs converting to, a failed proximal femoral fixation where the DHS is cut out and you convert it to a total hip replacement, they're often frail, they're often low demand. The trochanter is often not quite where you want it to be. I tend to not worry about it too much. I'll go in and do my standard posterior approach. So you sort of don't disrupt the muscle attachment of what is left attached to the trochanter. And often I find that actually the trochanter comes back down into a really quite nice anatomical position once you put the hip replacement in. And I don't try and fix it. I just allow the muscle attachments and the abductor attachments from the anterolateral aspect to hold it where it needs to be now that you've sort of reconstructed and reproduced the anatomy. And they're low demand and frail generally. So you get away with it, I think.
So I would agree with that. Less is more. For me, I've tried many metalwork solutions, not got any of them to look as nice as that case that Andrew just showed. And so for me, preserving the soft tissues and that vastogluteal sleeve is probably the key, really. So we're going to go over to you for we've whittled through these. We've come to the last case now, Andrew. Just a simple socket revision. That's what you're going to tell us about now. Is that correct?
Absolutely, Steve. I hope you've got a spare half an hour, but let's get cracking. So we'll have a look at this. This is a guy who's 75 years old. I didn't know him at this stage. He'd had bilateral total hip replacements, as you can see. He'd had problems on that right hip with some asymmetric polyethylene wear and some pain. Was seen by a colleague who had identified that he'd had a revision or wanted a revision or needed a revision with a right uncemented total hip replacement. The comment, asymmetric wear and lysis, I'm not sure of the stem design. So if we go to the next slide, he had a revision in August of 2014. The acetabular component was revised. The stem was left in situ, was revised to a 60 millimeter continuum socket with 3 screws. A 28 lipped liner was used with a 28 millimeter head. The surgeon involved used some Mytec actors to try and effect an abductor repair. And you can see there's the postoperative x-ray. Now, as you'll see from the next slide, on post-op day 1, he had his post-op x-ray. Everything looked good. On post-op day 2 and 3, he had severe pain. He was seen by the ward doctors and the physios. Pain was put down to his knee. And post-op pain, he had quite a lot of swelling in his leg, and he had a DVT excluded with a scan. On day 4, he was struggling, but was mobilizing slowly. And he was therefore discharged at 7 days post-surgery for outpatient physiotherapy. So if we carry on, Steve, he subsequently struggled significantly with his mobilization. He was advised by his physiotherapist to push through the pain, to work as hard as he could to reduce the pelvic obliquity that he described, and to work on his apparent leg length discrepancy. And then 8 weeks after the surgery, the surgeon involved was contacted because the physios were anxious that he wasn't making the progress they'd expect, and an urgent clinic review was planned. So, Steve, I don't think I need to ask you what that X-ray was expected to show. So he was seen in clinic straight away, and he's got a dislocation that's probably been dislocated a long time. So I was involved at this stage with a particularly unhappy patient and a very anxious surgeon. And we decided at that stage that we would try and get the hip back in joint as soon as possible. So we did our first re-revision. But when you look back through the notes, talking to the patient, he was saying that he hadn't been right since day 1. And you look at the notes, they're handwritten. They noted a previous leg length discrepancy. They noted the fact that he couldn't walk, apart from if he was on tiptoes on the hip that he'd had done. So there were a few little comments made there that I think are relevant in terms of his post-op. So if we go to the next slide, Steve. This was revision number 1. This was an urgent revision. This was a really difficult operation. You can see there that I've got 2 illustrious consultant colleagues, both assisting me in 2014 to try and get the hip back in joint. I assessed the socket at 50 degrees of abduction, 30 degrees of anteversion. It's an anatomical stem, and that's a stem that we should be aware of. It's basically an anteverted stem. I felt there was some posterior impingement that was causing that instability, or possibly caused the instability. The only head that we had available was a 32 millimeter head for that stem. And basically, I therefore revised the socket to a 32 millimeter liner. I turned the lip round anteriorly so that I protected myself anteriorly, left the stem in situ, and I was truly unable to redislocate that hip. So that was my first revision. He did pretty well. There's my X-ray following my first revision. So I've changed the orientation of the bearing, and I've increased the head size, and I've repaired the soft tissues. Unfortunately, Steve, this didn't do well acutely. And pretty soon after that first re-revision, he dislocated once again. So there we are with the X-ray. So I think the next one is a question mark, Steve, I suspect, as to what we were going to do. I don't know if you want to shout at me at this stage, or shall I humiliate myself by going on to what I did next?
No, I would suggest you keep digging.
Okay, I'll dig deeper. So at that stage, I decided that what we could do is to get hold of a revision head so that we could leave the stem. I really didn't want to take that stem out. And so I did a re-revision. Again, I felt the socket position was reasonable. So now I've increased the head size to 36. And so I've improved that. I used a bioball, which allowed me to functionally retrovert the stem very slightly, again with a 36 head. And again, I felt that there was no impingement at the time of surgery, and his hip felt very nice and stable. So the result of my re-revision, Steve, I thought was very good. Again, there's my X-ray with the 36 millimeter head and the changed orientation of the femur. And again, he did well, as you can see here. 2 weeks following his re-revision, well, with no infection, we carry on. But then 2 weeks subsequently, he dislocated again. That was reduced closed. Again, he did well acutely. Next slide, please, Steve. But again, 4 weeks following his revision, he dislocated again. So things were getting a bit personal now, Steve. I've done 2 revisions on this gentleman. I've done everything I can do without changing components. So I had to think about the components of the socket and the femur. And if we go to the next slide, my options really were pretty complicated to take out that stem. So I decided to do the whole thing. So I took out the stem. I revised that to a ZMR. I increased his offset. I basically took the femur out. I put in a large titanium shell with a dual mobility bearing. So I thought that in doing so, Steve, I had changed the orientation of the socket. I had got the offset right in his femur and put a dual mobility bearing in there. So I was really feeling quite good about myself, Steve, with my revision. And there's my post-operative X-ray. Again, I was quite happy with that. It all looked very nice indeed. And indeed, he did very well. No infection, he mobilized well. I protected him with a brace and everything looked very nice, as you can see, Steve, and we'll carry on through that. Things were getting quite confident about things. He was walking without support at 6 weeks following his revision. I went back through things about what I'd done and what I thought had happened, Steve, so we carry on with that. But then 12 weeks following his revision, he dislocated his dual mobility bearing. So you can see that shadow around the dual mobility on the X-ray. We popped it back in place. I did an aspiration because I was worried that he had quite a lot of fluid around the hip on a scan. So we aspirated his hip. There was no infection. There was some bleeding around it. Go to the next stage, please, Steve. There's the aspiration. I thought he was stable and he did very, very well. 4 months following that, he's doing quite well with his revision and his dual mobility and his osteotomies united, Steve. We'll go on to the next slide. And at that stage, everything was looking good. At 6 months following his quaternary revision under my care, he was building up his muscles, and I thought we could see him in 3 months' time. In time, I said that it'd be happy for him to return to swimming and cycling. At the present, I was just telling him to walk gently without his crutch. He felt sound out of his brace, Steve, so all was good. And I look forward to seeing him in 3 months until he dislocated following that again. So again, that was reduced close, again, was felt to be stable at that stage. If we move on to the next one. And then again, instability of that dual mobility. And then the next slide, please, Steve. So my problems now were really a difficulty. The hip was very tight anteriorly. I thought that possibly the socket wasn't as anteverted as I might want to make it. And so I converted then again to another socket revision, but this time to a captive liner with the ZMR in place. So no impingement, everything looked good to me. And if we look at the X-ray, Steve, there we are, and that's 2015. I maintained his contact and he's done very well, mobilized well. And here we are, Steve, next slide there. Next one, please, 2015, 2021. And he's done well. So we've had no further instability and everything looks good. So in terms of lessons learned, there are quite a few things about this. The first thing is there is no such thing as a simple socket revision. I think we really do need to be very careful about single component revisions and really assess both sides of the joint. Next bit, please, Steve. I think you should spend time with your patients. And this was a chap who I got to know very well. I think I maintained his confidence. I explained what I was doing. I obviously would not want to have gone through 4 revisions with one patient, but I did. You should always be aware of what other options you may have. But the most importantly, I think, is when a patient complains of increasing pain, reduced movement, a short leg, and can only walk in an equinus position 5 days following a hip surgery, get an X-ray. Thanks very much, Steve. That's my case.
Super. Fantastic case, Andrew. So many key principles reinforced there. I think each speaker tonight has used an important word, and that's communication. You know, these are challenging revisions, but they are even more challenging patients to treat. You know, they lose confidence in their hip, and some of the research that we've done has showed actually, although they're pain-free and they do and or can do okay, they adjust their lives because of the fear of this happening again. So all 3 of our great faculty this evening have emphasized that key message about caring for these patients and you know, upping your game when it comes to these challenges. So I'm not going to pot any more questions now, Andrew. I think you've all worked hard for the last hour. I'm going to just use that last case to, you know, just emphasize its patient factors, surgeon factors, implant design, implant orientation, and soft tissue factors. If we treat any of these problems in isolation, then we can get a very challenging situation indeed. So we've run a little bit over time, but actually we've stuck on 60 minutes. That was our maximum. So well done to you all. Thank you very much for sharing those challenging cases very honestly and helping us all learn and try and avoid this for both ourselves and for our patients in the future. So thanks very much to those who dialed in. Thanks, guys, for taking the time tonight to join us, and all the very best.
Bye. Thanks, everyone.
Thanks, everybody. Thanks, Steve.
Bye.